Hello, I'm Jordan Jones. I'm a pediatric rheumatologist at Children's Mercy in Kansas City, Missouri. And on behalf of my collaborator, Dr. Black, it's our privilege to present this topic today to you guys. We appreciate the opportunity given to us by the planners of this meeting. And today we'll be talking about establishing a roadmap to overcome barriers to Ehlers-Danlos Syndrome care. So a couple of points of interest that we're going to pick up along the way. One, I'm going to discuss a little bit about the complexity of EDS. We'll then move into some barriers that have been identified through some work that we've been doing. We'll identify some themes that are problematic for care and management of EDS. And then we'll move forward after we've identified those barriers and themes as to maybe giving some ideas as to how we can alleviate those barriers so that better care and management can be provided to patients with EDS. So I wanted to just quickly go over a little background on Ehlers-Danlos syndrome. It's a group of clinically genetically heterogeneous heritable connective tissue disorders. Most of the time when you hear about it, it's characterized by joint hypermobility, skin hyperextensibility, and tissue fragility. Again, when we're thinking about Ehlers-Danlos syndrome, it's reported that it's about 1 in 2,500 to 5,000 babies born annually with EDS. There are currently 14 recognized distinct clinical subtypes. The table on the right here shows 13 identified subtypes that were presented in 2017 when the terminology was revamped. And since that time, a 14th has been identified that's not mentioned in that 2017 paper, and that's called classic-like EDS type 2. Whenever we're thinking about EDS, there's also something else we have to talk about, which is hypermobility spectrum disorders. So a lot of people will go through the 2017 criteria for EDS, for hypermobile EDS, and will meet the checklist and get a diagnosis of hypermobile EDS. However, there are a lot of patients who have hypermobility. They have maybe some comorbidities associated with EDS, but they don't meet that strict criteria for hypermobile EDS. And these are the patients that fall into this hypermobility spectrum disorder. So as you can see from the table here, on the left side, we have the patients who have hypermobility, maybe generalized or asymptomatic, so they're very flexible but not having a lot of problems with their hypermobility. And then on the right side are those that have been diagnosed. And as you can see, there's this large group in the middle with different types of hypermobility, whether it's historic or peripheral or localized hypermobility that puts them into this group. It's very important that we keep this group in mind, as a lot of those with hypermobility spectrum disorders will have similar comorbidities and similar presentations to those with hypermobile EDS, even though they don't meet that criteria. Another thing to think about is some people will not meet the criteria one day, but maybe with time or later on, they will start to meet some of the criteria that gives them that diagnosis of hypermobile EDS. As we move forward, we'll be lumping hypermobility spectrum disorder and hypermobile EDS together, since they do suffer a lot of similar comorbidities. So this is a very overwhelming view of the complexity of hypermobile EDS. This is kind of the way I think about it, and this does not even take into account all of the things that can be associated with EDS or be impacted in patients who have EDS. So just kind of quickly walking through this, as you can see, starting with the EDS at the top, if you kind of head over to the left, a lot of patients will have the muscle weakness that will lead to dislocation, subluxation. That impacts their proprioception, how they feel their body in space and movement, which then leads to issues with posture and balance. And then because of the dislocations and issues with proprioception, we start to lead into issues with joint pain due to those dislocations, but also muscle weakness and fatigue. Other things that are impacted are baroreceptors. So you can see here in the middle, in the green box, vascular baroreceptors are impacted, which then can lead to volume shifts, which can cause issues with lightheadedness, dizziness, leading to POTS, and issues with blood pressure and heart rate not doing the appropriate compensatory thing that we expect them to do. There's also some evidence to show that those vascular baroreceptors have some impact in the menstrual issues that sometimes are experienced in female patients with EDS. Those baroreceptors that are in the gastrointestinal tract can then also cause issues with the stretching and the feedback that can lead to poor motility and constipation. That then can lead to issues with abdominal pain. Our sympathetic and parasympathetic activation comes into play that then impacts these symptoms more. And then we start to get issues with sleep impairment, mental health issues such as anxiety, panic disorder. Those then lead into issues with coping. And you can see how the complexity builds upon itself. And there's a lot of things that can be going on which can really overwhelm somebody who is not familiar with managing EDS, but also can really overwhelm a patient who is suffering with the condition of EDS. So that kind of brings us to the challenges that we face when we're thinking about providing care for patients with EDS. So as I just showed you, there's multi-system involvement, and it's all connected and it all feeds back onto each other. There's a lot of things reported about missed or delayed diagnoses and the problems that can come with that. So if patients are misdiagnosed, that might lead into the wrong or inappropriate treatments or inappropriate education given to families. Delayed diagnosis can then also have a similar outcome with not getting into appropriate care, which can then maybe impact quality of life or cause symptoms to get worse or build. Because of these things, we see that there's a lack of awareness of EDS, so people are unaware, which can then also feed back into that delayed or misdiagnosis. And then also building off of that is a lack of knowledge. So you do see a patient with EDS, but what do we do if we're not understanding or knowing what to do to start their care and management moving forward? And so this leads into a lot of other problems for patients with EDS. Things like inappropriate referrals where they're getting sent to places that they don't need to be, and this has been shown to lead to some distrust in medical providers and the medical institutions. We also start to see multiple referrals that then cause fragmented care. Providers are unsure who owns the patient or owns the symptoms, and that leaves the patients kind of stuck between providers. We already alluded to the delayed interventions that can then lead to more problems with getting appropriate care, improving symptoms, and then this can lead to quality of life deterioration. And then also another separate thing is just the long wait time. So we know that people who manage patients with EDS or who are aware of EDS, there are not a lot of those people, and so therefore they have long wait times, and it can be frustrating for families when they finally identify somebody who is aware of what's going on and can take care of them, but then they have to wait for a long time to get in, and again we have more delayed intervention, quality of life deterioration. And so you can see how these things continually build on each other and can kind of get into a bad cycle. So we're going down this road. We don't really know where we're at. What barriers exist around awareness and comfort with care and management of EDS? That was the question that we had. We wanted to kind of know, where are we starting? We don't know where we're at exactly. So this led us to develop a survey looking at provider knowledge and experience in care management and education of pediatric Ehlers-Danlos syndrome. We developed a survey that had 28 questions, focusing mostly on EDS awareness, looking at the diagnostic evaluation for EDS and providers' comfort with that. Also just looking at their comfort with care, management, and education for patients with EDS in general. We distributed this survey to pediatric and family medicine providers across 2 tertiary academic medical centers. This also included some hospital medicine providers, and there were also some subspecialists mixed in with the general pediatric providers, and this went out to trainees as well. So what we found is most of the providers were pediatricians, and that's not surprising considering we are pediatric providers, and that is who most of the surveys went out to. Interestingly, though, pediatric residents made up half of the response population, which initially we were a little concerned about, but it gives us a nice evaluation of looking at what trainees need versus what established providers need. Most of the people were located in an urban academic setting, and then also because of that number of trainees involved in the survey, we do see that our experience by years of practice is on the lower side, with the majority in the 0 to 5 years category. We then asked, what are people's experience with EDS? And the way we defined that was the number of cases of EDS you have managed. And 2/3 of the respondents said 0. So 2/3 have never managed a case of EDS. However, when we then went on and asked about how many patients currently have, how many providers currently have a patient with EDS in their practice that they're managing, 25% said they were not sure. So that's a pretty high percentage of people that aren't even sure if they have a patient they're managing that has EDS. So you can already start to see some barriers here. So moving on, we wanted to kind of know, how did people hear about EDS? How did they learn about EDS? We know the population here are medical providers, so we assumed most of them were going to hear about it through their training, through medical literature, and that is what we saw here, that most have heard about EDS through their medical training, maybe from a patient that they managed or heard about as well. When it comes to learning about it, same thing, mostly from medical literature and medical training. We then went on to ask about the 2017 EDS criteria, just to get a sense of understanding and how comfortable people were with that criteria. And as you can see here at the bottom of the table, if you look, we've divided this into people who are not comfortable, somewhat comfortable, and very comfortable, and almost 2/3 are not comfortable with this. Not surprisingly, when it comes to diagnosing patients with EDS, you would be using the 2017 criteria, and so if you're not understanding or aware of that criteria, it's going to be hard to use it to diagnose patients, and again, that's what we saw. When we asked providers in the survey about executing plans developed by a specialist, they were much more interested in doing that. They did not want to develop their own management plans, but they were much more willing to execute or carry out plans and care that a specialist had kind of put into place. So going to the barriers, when we asked about the barriers, it was kind of some similar things that we saw, and Dr. Black will talk a little bit more about these in a little bit, but we saw that some of the issues were educational materials. They just didn't feel that they had the educational materials they needed. They didn't feel they had the knowledge. A big one was confidence. A lot of providers did not feel they had the confidence to manage or care for patients with EDS. And that kind of makes sense. If you don't have the knowledge, you don't have the educational materials or know how to get those, it's not going to be easy to develop confidence. Same things for when we're looking at what prevented providers from managing patients with EDS. Same thing with lack of educational materials, but mostly it was that knowledge and confidence. I think interestingly, only a third of the respondents mentioned that they had a lack of time, and I'll mention a little bit more about that later. When we were looking at, we also wanted to get a sense of, are providers educating families with EDS or about EDS? And so we just asked, do you educate families about EDS? And only a third said they did. And that is not surprising. If you don't have the knowledge, if you don't have the confidence, you're probably not going to feel good about educating families. When we then stratified it out as to the comfort level with that education, again, very uncomfortable with educating families. So not a lot of people educating, and the ones that are not very comfortable doing it. And so kind of to dig into that a little bit more, well, what are the barriers that are preventing you from educating families with EDS? And again, goes back to lack of educational materials, lack of knowledge, also lack of confidence, and lack of time. But that knowledge and confidence were two of the biggest things that stood out. So in general, our conclusion from this study is that people felt generally familiar with EDS. I do think one of the limitations to our study, which we mention in our publication, is that we do have a multidisciplinary EDS clinic, and that could bias some of the providers in our region, but still we asked them not to take that into consideration, and there was still a general familiarity with EDS. Most expressed that lack of knowledge and confidence as barriers. I think I hammered that home pretty well earlier. Interestingly, the trainees reported more time limitations due to knowledge, more limitations due to knowledge and confidence. So that kind of makes sense. You're earlier in your training, you don't have that knowledge yet, you're building it, you don't have that confidence yet, you're building it. But then for the non-trainees, so the people who are out there practicing, they reported more time constraints. So those are the ones who are in practice. They're noting that time is more of an issue, but also the knowledge limitations are also an issue for them as well. As I mentioned earlier as well, that 25% were unsure if they were caring for patients with EDS. I think that also brings up an important issue that needs to be addressed, that the people are unaware if they're managing these patients just because of their knowledge and understanding. And then we also saw that most are more comfortable executing plans that have been established or given to them by specialists rather than developing their own management care plans. So then we're still going down this road. How do we improve knowledge and confidence with managing EDS? So we've now identified some of our barriers, some of our issues. What do we do with that? So as we're thinking about education and knowledge and what medical trainees are getting as they go through their education, when you look at the American Board of Pediatrics, this is the certifying exam that boards you in your specialty. You have to have certain competencies across many different subspecialties to then pass an exam and pass your boards and show that you have the knowledge to practice as a pediatrician. What I've highlighted here is only 3% of the test has to do with genetics. And then if you break that down, if you look at that 3%, that is broken down into further parts of genetics. So they might have something about basic genetics, clinical presentations, syndromes, or even the biggest portion is inborn errors of metabolism. So therefore, not only do you have to know a small amount about genetics, but then that's broken out into even smaller parts. So you might not have to know anything about EDS to pass your board exam. You might not get any questions about EDS on your board exam. So clearly, we've got to do better here, getting more knowledge about EDS and more common genetic syndromes in front of trainees. Another issue is workforce. So we know that a lot of subspecialties, especially pediatrics, are having major workforce issues and are predicting even worsening of those workforce issues. So this one just focuses on genetics. But in 2019, they looked at the genetics workforce and they found about 500 were practicing, a third did telehealth visits, and about 40% had a 3-month wait. And then what you can see from the diagrams of the United States at the bottom here is most of them are concentrated in kind of the northeastern area. What you see with the workforce, that FTE has to do with kind of how much clinical effort the providers have. And so those bigger circles mean they have more clinical effort devoted to seeing patients. And again, that northeastern area is more lit up there with red. Now, when you look at the other graph that has vacancies, you kind of see the same thing. They're concentrated to kind of bigger areas, bigger cities, northeastern, but even in those areas where there's a lot of practicing, there's still a huge need. And then there are you can see lots of states that don't have any workforce or vacancies available. So moving on, how do we improve clinical care? So we know that patients with EDS utilize a lot of healthcare. And that's not surprising. They have lots of comorbidities, lots of needs, are seeing lots of subspecialists and seeing them on a regular basis. As we talked about earlier, how patients can sometimes get fragmented care that can become an issue for them. We did another study that looked at patients with EDS and some of the things they were reporting during their care and then what kind of needs they had or wanted. And again, they noted lots of utilization of care, not lots reporting fractured care, going to several institutions to see several different providers across the area and larger region. And then something that emerged from that survey was that many wanted multidisciplinary care because that goes it takes that fractured care and kind of brings it into one place so that they can get multiple specialists, multiple needs met in one visit or in one location. Even a lot of them said they would be willing to travel quite far to get appropriate care. So clearly, there's a lot of needs that patients are reporting and ways that we can start to address those through improved clinical care. And one of the ways that we did that here was when we developed our multidisciplinary clinic. And so basically, we started with just identifying people who had EDS knowledge and interest and started pooling our resources together and then started offering that to patients. And we've been very fortunate and have had a very successful multidisciplinary clinic. Now I'm going to turn the presentation over to my collaborator, Dr. Black.
Hi, I'm Bill Black. I'm a pediatric pain psychologist in the University of Kansas Medical Center on the Kansas side of Kansas City. And to reiterate Dr. Jones's earlier comment, it is an absolute pleasure to be here speaking with y'all today. So as an extension of what you've already heard, clearly there is a need for us to develop some additional educational programming for our clinicians. We've already heard sometime today about just the need to improve access to patient care, patient diagnostics, and there just being a really severe limitation in terms of people available to do so, and even of folks who might be willing to not being comfortable. So we need to build something. Right? We need to develop some kind of program, some kind of intervention for our clinicians, those in training, as well as those who are currently practicing to help get them up to speed, which ought to be pretty simple to do, right? Maybe not. I think we've learned from other areas in clinical science that we can develop the best interventions based upon our expertise that we think will be impactful for patients, for clinicians, but that doesn't mean that we always are on the mark. And I think sometimes we develop things first and then worry about trying to get into the hands of folks who need it later. Fortunately, the science is shifting, and we're beginning to consider these things more so up front, earlier in the process when we develop interventions. And that was one of the things that we aim to do with the next part of our study. So we've not published this yet. We are currently writing it up. I've got a draft in my email box currently that's in my hands for review, but we all hope to have it out by the end of the month. Looking at qualitative factors that these clinicians then reported as being things that they might want to have or things that could be helpful for them to help address some of these barriers. And so as part of the survey that Dr. Jones already discussed, we asked 5 open-ended questions really to try and better drill down on what providers felt like would help them do some of these things better. What would improve their comfort in diagnosing EDS, comfort for caring, managing it? What would improve education they provide to families? And then lastly, what might they want to see in a workshop? If we were going to develop a workshop, what would we put in it to ensure that they get the most bang for their time and the most benefit from? So we analyzed these responses and then looked at themes across these questions. I think typically with analyses like these, I would present and look for themes on a question-by-question basis. But what we actually found is that the same themes popped up again and again and again across the questions. And so we categorized them that way. This probably isn't a surprise, and that's okay. It's nice to see that confirmation of evidence from both the quantitative survey as well as the providers are telling us, but the thing that popped most was that folks wanted diagnostic and practice guidelines. No matter how we asked the question, this came up time and time again. Wanting clinical practice guidelines, tip-offs for things of what to look out for and what they should be doing at their visits. Providers wanted to know what to do and how to do it with this patient population. Also, interestingly enough, it's not enough just to have the information. The way that they get the information, the way that they receive the knowledge also matters. Short methods, printouts, videos, modules, overviews, reviews. It really paints this picture of they also need it in a way that fits their practice and fits their workflow so that they can better and more actively consume the information that we wish to give them. Another theme that popped up was what to do about specialists. How to interact with specialists. When should they refer? To whom should they refer? How are these decisions made? Providers seemed more than willing to do so, but again, not knowing how to go about it. Do they call a rheumatologist or a geneticist? What would be the indications of one or another? Providers also expressed some concern about having access to referrals and specialists in order to support them in their management. So even if they were willing to do so, there was greater hesitance if they didn't know what to do with them after the fact. If they didn't know where the resources were or what other treatments were available in their area. And this seemed to be a pretty significant barrier for them as well. What I was also particularly excited about are that these providers also expressed interest in co-management and a willingness to do so. With guidance and collaboration from a team, from specialists. So really not just following instructions or not just handing these patients off, but really having an active hand in their care and ongoing management in collaboration with the team and folks who have greater familiarity with the condition. Dr. Jones alluded to this as well, that a big part of what these providers express wanting is just experience and exposure with the criteria, with potential guidelines, but also just with the patients themselves. And so I think this speaks to potentially a limitation of where they may be in their practice and training. It's not having more access to some of these patient populations to get that experience and to have that greater familiarity with how to go about handling some of these conditions. Once we got to the idea of workshop topics, the themes largely recycled themselves and just came up again in more concentrated fashions. So with qualitative analyses, you typically don't go through and count the number of times that people will make a response. But I think in terms of diagnostics, something like 30 or 40 of our respondents just like mentioned the need for diagnostics and diagnostic information as being part of a workshop. So I think that absolutely has to be a big part of any kind of EDS educational intervention for clinicians going forward, is how to diagnose it, how to use the criteria, and potentially ways to use that criteria in their own setting in terms of either quick reference pieces or increased familiarity so they can do it more quickly. These providers also want to know how to treat it in management. What are their roles in the management of EDS, whether they are a subspecialist themselves or whether they're a family medicine or a PCP. How do they factor into this? And then the third piece that came up repeatedly was when to refer out. I think these clinicians expressed a great willingness to get involved and to help manage these patients. And at the same time, also recognizing that there are probably limitations and times that they should go to specialist care. And they wanted guidance on these pieces as well. So if we're going to summarize this second part of our study, again, I think what these providers have demonstrated to us now in two ways, both their quantitative responses as well as their free responses to us, is they've got questions about diagnostics, screenings, what to look for, how do they recognize EDS when it comes into their clinic, as well as what to do for it. And not just what to do, but what works. Where's the evidence? What are the efficacious treatments for EDS? And they want more information about their roles in the management. When should they be managing? When should they refer out? When should it be co-treatment versus when should it be hands-off? And again, what was most encouraging to me was their willingness to do so. We did have, I think, 3 people throughout our entire response set that every response was just refer out, refer out, refer out, refer out, refer out. So clear for those 3 people, they want absolutely nothing to do with it. But we got great responses from a vast majority of our response set as seen here. So these folks are willing to get involved. They're willing to learn more, and they're willing to be active collaborators in the management and treatment of these kiddos. And they want this education. I think what this also showed is that they want it in any way they can get it, right? Whether it be lectures or online modules, brief handouts. So not only do we need to provide and establish something, perhaps building on current models like the ECHO series that exists, but finding ways to take that information and package it in multiple formats. So that if you are someone who just wants the handout, that's there for you. If you're someone who needs a quick rundown and a 5-minute video, that's there. If you're someone who wants it broken down into really more in-depth specialized modules, those are there at your fingertips for ease of reference. They seem really wide open to whatever they can get. And maybe that's reflective of the status of things, is that it's so underrepresented or so unaccounted for in current education, medical education, that folks want whatever we can give them. Right. And now I'm going to hand it off back to Dr. Jones to wrap things up for us here. Thank you for your time.
So now to wrap things up here, I wanted to show a picture for those more visual learners, kind of the way we think about this. So obviously the barriers, as we've mentioned today, shown today, talked about today, is the central area that we want to address, that we want to overcome. And this is, again, another very busy slide that shows a lot of work needs to be done. We have a lot of things to do, a lot of ways to go about doing this, but things that are going to improve the barriers. We talked about education, we talked about improved clinical care, we talked about workforce needs, but then, there are things that feed into that as well. So from an education standpoint, trainees are needing and wanting more education. We showed that they don't have to have a lot of knowledge in genetics, and that we want to change that so that they feel more comfortable and have more confidence in educating, managing, caring for patients with EDS. The providers want clinical guidelines. Those things can start to be developed. Handouts, seminars, all those things, that experience, those things that we've already talked about need to be developed. It is going to take some research to bolster some of these to determine, yeah, people want handouts, but is there a best way to approach that? Is there we develop something, we roll it out, we see what people think, what works, what doesn't, then we adjust it until we get to that sweet spot of things that are working really well for most people. And all of these things are then going to ultimately feed back into meeting the patient's needs, which is what we want to do. We want to overcome the barriers and meet the provider's needs so that they can then meet the patient needs. So again, the other side of things, clinical care. How do we do that? We need multidisciplinary care, which patients are wanting. They're asking for this. So we have to start figuring out ways to develop it, ways to grow it in different areas. That's going to take knowledgeable providers. Well, the education part can then build those knowledgeable specialists and providers that then can build that multidisciplinary care. So as you've seen, one of the themes that we're showing today is that this all builds upon itself. And if we start addressing these different areas, everything can improve. So now we kind of have an idea of where we're going. We have some things that we can start working for, so we know where we're at on this road. We know that we need to develop some clinical guidelines. We need educational resources, maybe some shadowing experiences or hands-on experience for trainees or interested providers. We know we need multidisciplinary care clinics, more trainee education, determining different models. We've proposed some here, but maybe there are other models that we're unaware of or other people are doing that could or are successful. Things like a consultative model where you can call up or have access to knowledgeable people who manage or see EDS on a regular basis, who can then answer questions quickly for you. And of course, as we've started this research on these needs, we're going to need a lot more research on these areas to tailor these needs to better meet the provider wants and the patient needs as well. So we now have our roadmap. We now know where we're going. We now know some of the things we have to do. And this is by no means comprehensive, but at least gets us going in the right direction. So with that, on behalf of myself and Dr. Black, special thanks to the patients and families that allow us to be a part of their care. It's so meaningful. We also have a great multidisciplinary care EDS clinic team that we work with regularly, and we're very fortunate that we have amazing people that we get to work with on a regular basis. We also have our EDS research team that Dr. Black and I are very involved with, who are doing amazing things in this vein of work with education and providers, but also in many other areas of EDS. And then, of course, we have to thank our funding sources that allow us the opportunity to continue doing this work. Different foundations, philanthropic support, and government support. So thank you very much.